Is Mickey, and I'm going to demonstrate to you how to intubate a patient. So first, what we want to do is we want to look at the patient's chart. We want to assure that the patient meets the proper indications. So some indications in regards to intubating a patient would be if the patient is in cardiac arrest, is having respiratory failure, or if the patient is a pre-op patient, meaning that they're getting ready to go into surgery, or a drug overdose patient. A contraindication in regards to this would be a patient who is a DNI, which is a do not intubate type patient. Some complications that can happen with this is that the patient could vomit and aspirate, and it could cause some airway trauma. Another thing that we want to look at in the chart is that we want to look to see if the patient has had any prior intubation. If so, we want to look at what size tube was used. We want to see if it was a difficult intubation. We want to also look at the patient's chart for their Patty score, and any other orders that the patient, the doctor put in, and we want to look at any trending vital signs. Okay, so we want to go ahead and gather our equipment prior to entering the room. So we want to make sure that we have a properly functioning ambu bag. The way to check it is we want to look at the duct valves, make sure that they open and close. We want to go ahead and occlude the opening. We want to make sure it does not deflate. Then we're going to open it up. We're going to occlude the airway, the opening, and make sure that it re-inflates. We want to make sure that we have a mask that has proper pressure for it. We want our secure ties, our stethoscope, our laryngoscope, and we want to make sure that it's working. So we want to make sure that the light turns on and it's functioning. We want our blades. So there's two different types of blades. This one is curved and it's a Macintosh blade. The way that this one works is that it indirectly displaces the epiglottis, therefore it goes through the vallecula and it lifts it. The Miller is a straight blade, and this one directly displaces the epiglottis. We want our tubes, so our endotracheal tubes. So we want to have two sizes. One of them we want to have the same size that the patient is needing and a size smaller. We want to make sure that we have a stylet to help us guide the endotracheal tube. We want a syringe so we could make sure that we check. This is going to help inflate and deflate the cup on the endotracheal tube, and so we want to make sure that it properly works. So the way that we do it is we go ahead and we're going to open it, and we're going to inflate the cuff so we see it inflated. But when intubating the patient, we want to assure that it is completely deflated. We also want to have lubrication, so we could go ahead and place on the tube to help better guide the tube in the inserting the tube. We want to have our CO2 detector, our OPA, our bite block. We want some gauze, our bougie, our suctioning tube, our Yankauer, our gloves, and 3 mLs of hand sanitizer. We also want to have some Miguel forceps just in case we need them. So what the Miguel forceps are used for is the way we're going to actually intubate the patient is it's going to be visually done because we're going to visually see the airway. However, if we were to do another type of endotracheal tubing or another type of procedure way, it would be a visual but through the nose, and so we would use the laryngoscope and the Miguel forceps to help displace the vallecula or move the vallecula so we could go ahead and see the airway to insert the tube through the nose, and that's a visual technique. And a blinded technique would be if you do not have the Miguel forceps and you need to insert the endotracheal tube through the nose and you're just hoping that you get the airway. That's going to be the blind technique. So then we're going to go ahead and as I got my 3 mLs of hand sanitizer, we're going to go into the patient's room. So I'm going to knock and identify myself. Hi, my name is Mickey. I'm a respiratory therapist student. I want to make sure that I have the correct patient. If the patient has not yet been sedated, I'm going to ask them to state their name and their date of birth. If they are sedated already, I'm just going to check their wristband again to check for their name and their date of birth. I'm going to acknowledge any family members that may be in the room. And so I'm just going to go ahead and, hi, my name is Mickey. I'm a respiratory care student, and I'm going to go ahead, and it looks like your loved one is having difficulty breathing and maintaining an open airway. So we're going to intubate them to help open up their airway, to help them breathe better. Some complications that could happen is that the patient could have airway trauma, they could vomit and aspirate. Okay? Do you understand the procedure?
Yes.
Do you have any questions? No? Okay, thank you. What I'm going to also do is I'm going to go ahead and obtain the patient's vitals. So I want to listen to their breath sounds, check their heart rate, their O2 saturations, and I want to make sure that I have a towel as well, so for the patient's comfort. And I want to make sure that our oxygen is properly working, because when you're going to intubate a patient, we want to make sure that we fully oxygenate the patient prior to intubating. So we would be able to crank this up so that we could be able to provide 100% oxygen. We want to check our pressures in case the patient is going to need some suctioning. So the pressures is going to be, if it were to be an infant, the pressures would be 80 to 100. If it's a child, it's going to be 100 to 120. And for this case, for an adult, it's 120 to 150. And when intubating, you only have a minimum of 30 seconds to attempt to insert the tube. If you are unsuccessful, then you stop, you remove the tube, you oxygenate the patient again and provide them with 100% oxygen until there's that maintain 100%. Okay, and then you attempt again and again. You only have 30 seconds to do this procedure. You want to position the patient, if you want to properly position the patient, if they are if they have a cervical injury, then you would do a jaw thrust. Other than that, then you would just go ahead and place them in a sniff position. Sorry. And so I'm going to go ahead. So this is Ruby. She's going to now be helping me. She's my assistant. And I'm going to go ahead and perform. Okay. Okay, so you want to be careful when you're removing the laryngoscope. Okay. And so I'm just going to go ahead, and my partner just inflated, we're going to go ahead and inflate the cuff, and I'm going to go ahead and remove the stylet. Okay. And then I'm going to make sure that there's correct placement of the tube. And so the way that I'm going to do that is, if you could just hold the tube for me, please, while I check. And so I could already tell that I could see there's a rise in the stomach. So I would listen, and I could see that I did not get the lungs. So what I'm going to do is I'm going to go ahead and remove the bag. And I'm going to deflate. Okay. We're going to remove this. We would be obtaining a thank you. We would be obtaining a new tube. So again, we want to go ahead and oxygenate the patient, and then I'm going to go ahead and attempt it once again. Okay, so I went ahead and obtained a new tube and provided them with 100% oxygen, and I'm going to reattempt. Okay. Okay, so I'm just going to be careful here. Going to remove the stylet. Okay, going to inflate the cuff here. Okay, hold the, okay, if you could just hold the tube for me, please. And I'm going to go ahead and check the patient's stomach first. Listen. Check the stomach, make sure I don't hear no air in the stomach, which I didn't. So now I'm going to bilaterally check and listen to the patient's breath sounds. And listen bilaterally. Okay. There we go. And so when inserting the tube, we want to make sure that the tube is 3 to 5 centimeters above the carina. And so what we would do is we would order a chest x-ray to confirm that. That's the proper way to confirm that the tube is 3 to 5 centimeters above the carina and it's placed correctly. We also look at the CO2 detector. It's going to turn from purple to gold. Gold indicating that we are in the lungs. We're going to check for condensation on the tube as well. And I also want to see when inserting the tube, we want to have the tube for males, it's going to be 21 to 23 at the teeth, and for females, it's going to be 19 to 21. Right now, so again, we would be checking, having an X-ray to see if it's too far in, then we would go ahead and readjust the endotracheal tube if that were to be the case. Okay, so then if you could just go ahead and hold the tube. Now I'm going to secure the tube. So I'm going to use my ties here. If you could just go ahead and hold it up here for me, please. Okay. And oxygen. Okay, so I'm just going to and when securing the tube, we want to assure that we don't tie the balloon with it. Okay, and so then we just want to go ahead and put this underneath the patient. Okay. We want to make sure that it's nice and tight. Okay. And then if this is too long, then we would just go ahead and cut it. And then we just want to make sure that we could get 2 fingers in. And then we would also obtain, we would place the suctioning tube on the patient. So we could go ahead and place them on the ventilator, on the mechanical ventilation, and attach the HME to it. And then we could go ahead and place the bite block in there because we need this. We don't want the patient to be, biting our finger off later on when they wake up. Okay, so you just place that in there. And then you would just use this just to go ahead and you would remove the tape to secure it. Then you would just add the gauze so that the patient could not get any skin lesions or anything like that. Okay, so the tube is nice and secure. Then we would go ahead and listen to the lungs again. So we would listen bilaterally to the lungs. And we want to make sure that there is no crackles. Because if there's crackles, then we would go ahead and suction the patient. Now, if the patient were to be intubated for a long period of time, we want to avoid a long period of intubation, because if they were to be intubated for a very long time, then that could cause vocal cord paralysis, vocal cord necrosis. We also want to assure and so we want to avoid that. We also want to check the cuff pressure. So we would use a manometer to check the cuff pressure. So the pressure that we're checking for would be from 20 to 30. If we do not have a manometer, then we would go ahead and use our stethoscope to go ahead and listen for a minimal leak and a minimal occlusion. And a minimal leak will be if it's occluded too much, then we would go ahead and deflate the cuff a little bit just until we hear a slight leak. So that's the minimal leak technique. If it's deflated too much, if the cuff is deflated too much, then we would go ahead and inflate the cuff just a little enough so that we could only hear a minimal leak in the airway. So we could just go ahead and check it, and then if we need to release a little bit during the minimal leak, then we just deflate it a little bit. Okay, so then I'm going to go ahead and gather all my equipment, dispose of it properly, make sure that we send this to get autoclaved and cleaned, the laryngoscope, and throw away any of the stuff that we don't longer need. I'm going to go ahead and remove my gloves. I'm going to hand sanitize my hands. I'm going to clean my hands. Then we're going to go ahead and document, and we want to document the placement of the tube, where it was at the teeth, whether it was a difficult intubation, and then of course we want to order the x-ray again to check the 3 to 5 centimeters above the carina, and then in case there were to be an ABG order, we want to wait half an hour after the patient was intubated so that we could go ahead and proceed with the ABG. And then I would go obtain also the patient's vital signs. Once again, aside from listening to their breath sounds, I would go ahead and check their heart rate, respiratory rate, their saturations. And yeah, so that's the way it is to perform an intubation. Thanks.